think this is my 20th reorganisation, and most of them have made little difference, and some have made no difference. But this one has the potential to have a bigger impact, and this one needs to have a bigger impact because we face a future in which need will increase and demand will increase, but there will be no more money. We've also got to get by on a lot less carbon. Now, when I look at healthcare in this country or in any country, I see it as an archipelago with 4 big islands: general practice, hospital services, mental health services, and community services. And there's an occasional ferry boat going from one to another, as you can see when you're on an aeroplane looking down at the sea. But they haven't really changed much. And the way we've contracted for healthcare has also focused on these big islands: more hospital care, more investment in general practice. But of course, for people with musculoskeletal disease, this is artificial. They have problems their GP deals with, problems their hospital deals with. Many of them have psychological problems, not surprisingly, and they need community services. So instead of 4 islands, it's better to think like a Russian doll, not with these same names, but with self-care, informal care, generalist care, and specialist care. And there may be a case for super specialist care. But in the course of a year, people with musculoskeletal disease will have all these problems. Now, the first thing that will happen is that we will be allocating budgets much more by programme budget. And the spend on musculoskeletal disease is about £100 million per million population. And commissioners will get into the detail of this. They'll be expecting clinicians, people like you, to think of what's the right balance between rheumatoid arthritis and osteoarthritis and joint replacement, osteoporosis, and rarer conditions like lupus, SLE. So that's the first thing, programme budgeting. Commissioners will make decisions about how much into musculoskeletal and how much into respiratory and how much into cancer, but I don't see a lot of money shifting about because we know that in every service there is scope for getting more value out of what's available. So within the programme budget, there'll be discussions about allocation between the different systems, and that will be people like you. This means we've then got to focus on what I've called within system marginal analysis, namely, what's the right balance between investment in diagnosis, drug treatment, surgical treatment, physiotherapy, social support. And again, that will be the responsibility of the clinicians with patients involved. The best example of this is a report from an organisation called IMPRESS, IMPRESS, which is the British Thoracic Society and GPs interested in respiratory disease. And they said, for example, before moving to triple drug therapy, we should invest in smoking cessation and in rehabilitation. So the clinicians and patient organisations will be involved in making decisions about the balance of spend within the programme budget for musculoskeletal disease and within each system. Now, what we are trying to do with the QUIP programme is to help people think through system design. If I were there, I'm very sorry I'm not, I have to see the Chief Medical Officer, I'd be saying, well, let's just ban the use of the words primary, secondary, acute, community, outpatient. They're 19th, 20th century words. And the new words are system, network, pathway. And I know you've done really good work already in Sheffield. We're coming to learn from you. For us, a system is a set of activities with a common set of objectives and an annual report. And in setting objectives, which is one of the things we'd like you to do, I aim usually for less than 10 objectives. For example, to diagnose rheumatoid arthritis quickly and accurately. So I think the objective setting is at the level of, say, rheumatoid arthritis or joint pain. It's at the system level. And that's what we hope will come out. You may well find this is very familiar territory to you. What I find usually is that really good services, like in Sheffield, you're thinking systems anyway, but you've never had to write it down because you do it like riding a bike. It's tacit knowledge. So to help other people, we like to make that tacit knowledge explicit. Once you've got the objectives set, then you have to identify criteria to measure progress or the lack of it, and to set standards. But in our experience, getting the objectives agreed, then starting to think about the right size of population is also very important. Now, when we look at healthcare and we think of population-based systems, often we look at the traditional catchment population of a hospital, but it may be some things require a bigger population. And the British Orthopaedic Association is certainly saying it sees the need for much bigger populations for joint replacement services. So try to think of, take a map of England and just start drawing. How many population-based services for rheumatoid arthritis are there in England? Should there be in England? Because I suppose that's the bottom line for us. At the moment, we can answer questions about institutions like hospitals. But the question for us is, for example, is asthma care better in Somerset or Devon? Is epilepsy care better in Liverpool or Manchester? Is care for people with rheumatoid arthritis better in Northumberland or in Dorset? How many services are there for people with joint pain in London, and who's responsible for them? These are population-based questions about value. So we're very grateful to you for helping with the Right Care programme. I know you're doing excellent work already, and I thank you for being involved with this. Thank you very much.